So, good morning, Oliver.
Good morning, Simona.
Morning.
Nice to be with you. I was a little bit confused because I scheduled
Yes.
the CET time, actually, not the Romanian time, but I'm there. Thank you.
So you were not the only one which was confused because our previous speaker, I think, the rheumopediatrician was also maybe a little bit confused, and that's why we changed a little bit, and we had already a talk from this section before you. So thank you to be with us, and thank you because you are one of the best people to talk us about interstitial disease in systemic sclerosis and about what's happening now in this field. Thank you, Oliver. Thank you.
Thank you very much, Simona, for the kind introduction and invitation. It's a great pleasure to be with you. And you remember that we planned for this last year already.
Yeah.
And now we see how long COVID is keeping us in our local areas. So it's still nice to be with you. I would like to discuss with you today in the next 30 minutes the new treatments of scleroderma ILD, because we will have a look whether this is now a true breakthrough or if that is still something minor as we had it for many years in scleroderma overall. So I have to see how I can control actually the slides. What do I have to do?
From the arrows or? Yeah,
it's a little bit delayed, I think.
Yeah,
but
yeah.
This is my conflicts of interest. I will talk about many medications, and I'm, as you see, consulting many companies in the drug development. So that's important for transparency. And just to make the point, I think most of you will know that, but just to look at it again is important. Interstitial lung disease is the most frequent cause of death in scleroderma. And this is a more recent analysis from Muriel Elhai from the EUSTAR database. And the EUSTAR database is large, and Romania is one of the most significant contributors to the EUSTAR database. Thank you very much for that. And that database has now almost 20,000 patients. And in this analysis from 16-17, we were able to look at 940 deaths from 11,000 patients. And you see the causes of death, and you see that lung fibrosis and PIH, so the two lung manifestations, main lung manifestations, are the most frequent cause of death. And for lung fibrosis, interstitial lung disease, it's the most frequent cause, in particular in diffuse patients and in the overall cohort. But keep in mind that limited scleroderma patients also can develop a very meaningful interstitial lung fibrosis. That's important for you to follow up with the limited cutaneous patients, which can lead to death, which you see here in the light green bar. So that's a significant contribution to death, even in the limited systemic sclerosis patients. What I will do in my talk, I will use the European consensus statements that Karina will talk in much more detail about, and I will not talk about the methodology because Karina will talk about that, and Karina will talk about all the other parts except for treatment. And this is the reason why I will only focus on treatment, not talk about the methodology, but just to say this is a consensus statement, and a consensus statement is just much more valid than an individual opinion from anyone who is involved there, because it's reflecting a large proportion of experts in the field. And what I will also try to do, because we can really do this now, right? And this is, I think, one of the new things. We can apply evidence-based medicine in our treatment decisions in scleroderma ILD patients. And this is really new, because before that we really didn't have enough clinical studies that they could rule our clinical decision making. Now we have them available, and this is the new, and I think really the breakthrough in scleroderma ILD. We can do evidence-based medicine. And this is a reminder of the Oxford grading system for evidence-based therapies, and I will try to apply it to the different clinical studies and treatment options that are available. Level 1 is high-level randomized controlled clinical trials with positive endpoints. If there are more clinical trials where you can do a meta-analysis or systematic reviews, it's 1A, and if it's less so, it's 1B or even 1C. Level 2 means cohort studies, or I count actually randomized controlled clinical trials with secondary endpoints into that, or with negative clinical trials which have evidence from secondary analysis from studies done for other purposes. And level 3 is really case control studies, individual case control studies, and 4 is case series or case reports. So just to remind you of that, and that is now the first statement from the consensus paper published in Lancet Rheumatology. Karina will let you know that you can freely access this on the Lancet website and have a look at this. So what did the expert recommend? Well, first they said there are some options, some situations, some patients where you don't need a treatment. And these are patients with a very long-standing disease, with no activity for a very long time in their ILD, and where you have no risk factors actually for progression available. There is a possibility of watchful waiting. So you need to follow them up. You need to watch them actually. But still, you don't necessarily need to treat those mild, stable, long-term patients without any risk factors. That's the opinion, and I agree. We don't treat every ILD that we see in our patients. All other cases actually should be treated, and the experts recommended MMF, mycophenolated mofetil, cyclophosphamide, and nintedanib for the treatment of scleroderma ILD. So let's have a look at these different treatment options, and let's have a look how the evidence level for these treatment options is in scleroderma ILD. So this is all data. All of you probably know it. That's scleroderma lung study 1 with cyclophosphamide versus placebo. Very well done, investigator-initiated, a US trial funded by NIH. Primary endpoint was forced vital capacity at 1 year, 12 months, which is already quite long, as many of us are using it shorter for 6 months, usually with IV pulses. This was oral, so there are some differences. But there was a significant, statistically significant difference at 12 months. And if you do sub-analysis, it also became clinically significant because those patients also had, at least in the more severe cases, also patient-reported outcomes that were better. And there was a sub-analysis for skin fibrosis that was also pointing to efficacy on skin fibrosis. So this is nice. It's a positive study. It's a well-done randomized controlled clinical trial that has a positive endpoint. It's meaningful. So that is probably level 1. Maybe it's level 1B because it's the only really study that fulfilled the endpoint. So there are other smaller trials that were not powered that all indicate potential efficacy. So I think this is 1B, good evidence for treatment with cyclophosphamide. The limitation is, of course, shown on this slide here. That's another study that is looking at a longer-term follow-up of those patients. And you see that those effects of cyclophosphamide continue to be there for a while, for another 6 months at least, but then they tend to disappear, and then there's no difference against placebo anymore. And the reason is you cannot continue with cyclophosphamide. So this was given orally for 12 months here, and then it had to be stopped because of the cumulative toxicity. And that's the major limitation. One shouldn't treat that for too long because of the dose-dependent, cumulative dose-dependent toxicity that is known for cyclophosphamide. So that's the major limitation, but we have good level of evidence here. Then the new data are coming from nintedanib. That is has been published almost 2 years now ago. That is the large randomized controlled clinical trial with nintedanib against placebo. Again, this is a similar clinical trial design, primary endpoint, forced vital capacity, 1 year. And by purpose, I'm showing the placebo group first because the population that was recruited into that nintedanib trial, the census trial, was really relatively broad, much broader, for example, for SLS1 and much broader than for tocilizumab, which we will have a closer look at later. So that is a relatively representative population of patients that we see in our clinical practice that have ILD. And I think the only meaningful limitation as an inclusion criteria was that they had to have more than 10% involvement of HRCT, lung fibrosis on HRCT. That's maybe the only limitation that is a little bit enriching that population. And in this population, which is not much enriched, the average decline of lung function is 90 milliliters, 90 to 100 milliliters, right? And this is shown here. That is important because it's not huge. It's much more than the natural decline, which is around 20 milliliters. So that's a true difference of 70 milliliters. In that 1 year, the patient probably doesn't feel it. So if you ask an average patient of our population after 1 year, do you feel worse with your dyspnea? They probably say no on average, because the 90 milliliters is below the minimally clinically important difference, which is 120 milliliters. So that's important to understand when we look at the clinical meaningfulness of these results. The study was positive at a p-value of 3.6%, so there was a 44% difference, 41 milliliters that favored nintedanib. So nintedanib slowed the progression, which is also shown on this longitudinal slide graph over time. You see that there's a separation between 12 and 24 weeks, where the nintedanib patients are stabilizing and the placebo patients are worsening, actually more than the nintedanib patients. And I like this slide a lot. It's a cumulative distribution plot, and we have to learn to look at these kind of slides. I like it a lot because it shows how where nintedanib is actually having effects. So let's first look at the light blue placebo group here. You see that there's no change, means 0. And you see that there's a proportion of around 20 to 30% of the patients that have a mild improvement under standard of care with their forced vital capacity, up to 5, maybe 10%. Then there's a larger group of patients that are stable in this representative scleroderma ILD population. And there are some patients that are worsening by more than 5 to 10%. And that's a proportion of 20, maybe 30% of the patients. So that's the placebo group. And when you now look at nintedanib, you easily see that the efficacy of nintedanib is across the natural course of the disease, right? You see more patients that are improving, you see more patients that are stabilizing, and you see somewhat less patients. So that is not the main effect, as you see here. You see somewhat less patients that are progressing, right? And I think this is important to understand, right? So on the individual level, when you ask a patient, that creates some difficulties, right? Because when you ask the patient after a year and he's coming back and he's saying, that didn't help me, I'm the same, you're saying congratulations, because you had a higher likelihood with nintedanib to be stable. And I think this is important also in the management of the patients to understand this. So this is a large clinical trial. So this is already level 1, that is positive, evidence level 1. But there's more data now actually available. And this has been presented at conferences and is in the process of publication. It's not yet published actually, but it's in the process of publication. And this is a specialty of the design of the Sensis trial, in that they had 52 weeks at their primary endpoint, but the patients were continued in a blinded way, either on placebo or nintedanib, up to 100 weeks, until the last patient in the clinical trial, with the 600 patients, had reached the 52 weeks. So this creates a meaningful proportion of patients that continued in a blinded way for another year, right? And the numbers are meaningful, as you see here, 90 patients in both groups. And you see two different analyses, intention to treat and on treatment analysis. You see that there's almost no difference, leading to the same results, independent of how you do the analysis. And the message is that the annual decline is continuing in the second year, right? And this is an important message, because there's really the question, the efficacy of that 1 year is only, it's 40 milliliters, which is significant, but clinically meaningful, this is only becoming if that effect is continuing over the next years, right? Because then it's another 40 milliliters, another 40 milliliters, and so on. And then it, of course, becomes meaningful. And this is encouraging because it indicates that this effect is continuing into the second year. And there's even more data now available. And this, again, has been presented at the ACR meeting, not published yet. And this is the Sensis On trial. So this is an open label extension. So after that 1 or 2 years, up to 100 weeks, 52 to 100 weeks, the patients were offered to continue open label on nintedanib, the Sensis On trial. And you see that the number of patients was actually meaningful. So most of the patients actually switched, almost 200 patients in nintedanib and 230 in the former placebo group that switched to nintedanib. And there were a few patients coming from another small study into the clinical trial. And here's the main result of that clinical trial that has been presented, is again in the process of publication, not yet published, but shown at ACR. You see first, as a comparison, the primary endpoint of the Sensis trial. Again, this population that continued had in the placebo group a worsening of 100 milliliters and 42 milliliters in nintedanib. And here you see Sensis On. So the patients that newly initiated nintedanib, that were on placebo, had a decline of 44 milliliter, almost the very same as the treatment group in the randomized controlled clinical trial part of the Sensis trial, which was 41 milliliters. So almost a to the point repetition of what we had seen in the treatment group of the randomized controlled clinical trial. And again, encouraging is that those patients that continued nintedanib now into the second to third year, had a little bit more decline, but in the range that had been seen over the first 2 years, right? Again, this is encouraging and indicating that that effect is continuing into the third year as well. So that all indicates that there's a long-term efficacy of nintedanib available. So if we summarize that, we have a large randomized controlled clinical trial. We have additional data on the 100 weeks and the long-term extension, the Sensis on data, that is all pointing to a long-term efficacy of nintedanib, and is repeating that what had been seen in the randomized control part of that clinical trial. So this is creating a quite high evidence level. I think it's still 1B, but there's also additional data available from the inbuilt trial. The inbuilt trial was done in parallel with the Sensis trial and recruited patients with progressive ILDs of all kind of forms except IPF, right? So that included, of course, CTD patients, patients with autoimmune disease-related interstitial lung diseases. This is the overall population, including all kinds of progressive interstitial lung diseases, which we as rheumatologists rarely see. But this is the subgroup, is the autoimmune-related interstitial lung diseases, mostly rheumatoid and scleroderma ILD and mixed connective tissue ILD. And you see that there is a meaningful difference as well, right? So this is giving us additional evidence that there's another study that there is indeed, particularly in the progressive ILD patients, that there is a meaningful difference. This is the sub-analysis for the different connective tissue diseases. You see that the RA-ILD population made a meaningful part of that. And you see that there is the 95% confidence interval is largely on the right side, despite this is not at all powered with very small patient numbers. And there's no treatment by subgroup by time interaction p-value that is indicating differences among those groups in their treatment response. So this is at least 1B. It's not yet 1A because nobody has done really a meta-analysis on this or has done a systematic review that is combining all those papers, but it's a very high level of evidence. So we have a new level 1B, at least level 1B level of evidence for nintedanib as well as we had it already for cyclophosphamide. What about mycophenolate mofetil? I think when I ask you, I'm not sure if MMF is easily available in Romania, but when I ask people around the world, and if you look at the treatment use in scleroderma ILD, MMF is the leading treatment across the world. Most people use MMF across the world if it's available. Let's look at the evidence for that, because I think you will be a little bit surprised. So this is the best evidence is coming from scleroderma lung study 2. That's an RCT comparing MMF and cyclophosphamide. It was designed as a superiority trial, superiority of MMF over cyclophosphamide. MMF was given for 2 years, cyclophosphamide for 1 year because of the toxicity, and then there was an extension for another year without cyclophosphamide. And the investigators were planning that MMF of 2 years should be superior to 1 year of cyclophosphamide. And you see that the primary endpoint was not met. This is a negative study. 2 years forced vital capacity is not different between cyclophosphamide and MMF, as you easily see here. The study is still interpreted to be positive, right? Because there's an improvement of forced vital capacity, which we rarely see. You've seen the Sensis trial data already, and many other data pointing to the same. Usually there's a progression of ILD, not an improvement on the average on a forced vital capacity. And of course, we have other data that is indicating efficacy of MMF. And one of them is coming from the Sensis trial. There's now new data coming from the lenabasum trial that is not yet published, but there's a press release. And this is pointing to the same direction, actually. So secondary analysis of other clinical trials, for example, the Sensis trial. And here, if you compare patients that were taking MMF as a background therapy, that were around 50% of the patients, and we compare the 2 placebo groups that were not given nintedanib, the light blue bars, you see that there's a larger progression in the group that is not taking MMF comparing to those that are taking MMF. And the best progression, the slowest progression is seen in the combination with nintedanib and MMF. This is, however, not the same level of evidence, right? Because of course, this is neither blinded, that was open label. They could have taken MMF and they need to have taken MMF for already 6 months. So this is an add-on therapy. It's not powered for MMF. It's not randomized for MMF. And of course, they had baseline differences, the 2 placebo groups here not taking or taking MMF. So it's not the same level of evidence. We are missing a primary endpoint randomized controlled clinical trial. But there is indirect evidence from other secondary analysis, from retrospective analysis. So there's more data coming that is supporting MMF use. However, it's not reaching the evidence level that we have for cyclophosphamide and MMF. You should be aware of that, right? Still, of course, also we in Zurich, Karina will confirm, are using MMF quite frequently because of that indirect evidence. Level of evidence is probably not 1, right? Because we are missing a randomized controlled clinical trial that is positive on the primary endpoint. But it's at least level 2B, if not higher, 2A maybe. That is indicating efficacy of MMF. There were a lot of concerns that a combination of MMF and nintedanib might cause toxicity. And the really good news is that if you look at diarrhea, which is the most frequent adverse event of nintedanib, and you compare patients from the census trial taking MMF and not taking MMF, then you see that, for example, diarrhea is not at all different, 75 to 76%. It's really the same. So adverse events, and there was no other signal actually, adverse events are not occurring more frequently in the combination therapy than with individual treatments. That's an encouraging toxicity information for combination therapy. So what happens if these medications are not working? Then the experts recommended to use one of the other medications. You can use one of the ones that have not been used in the first line, and they recommended rituximab as second line therapy. We will not have time because we are limited to 30 minutes, and I'm coming already quite close actually. So we will not have time to talk about rituximab. So far, the evidence level for rituximab is relatively poor. The best study is there are a lot of observational studies, which are fine, but which are not increasing the level of evidence to a high level. Observational studies, very small case series, a very, very small control study with a very few, I mean, almost non-control patients. And one Indian study that is published 2 years ago, one Indian study that was randomized and looked at cyclophosphamide against rituximab, showed positive effects for rituximab, but that was a relatively small number of patients, not blinded, and in a one-center approach. So that needs confirmation. The good news is we will see randomized control trials of rituximab very soon. So watch out in the next, I would say, weeks or months at least, until EULAR. There will be coming more evidence, and that will change the evidence level of rituximab. So then we have to reanalyze this actually. Stem cell transplantation is an option. I'm referring to the EULAR treatment recommendations because that is still updated. High level of evidence, 3 randomized controlled trials, 2 of them very good, showing efficacy also for lung, also on forced vital capacity. And of course, the limitation is the treatment-related mortality of 10%, limiting it to quite a few patients where we can apply it. And lung transplantation has been mentioned here. We should list those patients early enough. I have to say it's not 100% clear when we should list them and whom we should list, right? I think this needs more analysis and more recommendations and more studies. So when you look back, there's a term, when there's a progression, you should switch treatment, right? And there's no statement at all about combination therapy included. And I would like to show you a recent analysis that we did and is published in Annals last autumn, actually, that we did with the EUSTA database. And we looked at the progression of patients and analyzed the pattern of forced vital capacity changes over time. And over 1 year, that were patients that had a long-term follow-up and were fulfilling all the inclusion criteria, had HRCT, proven ILD. And when you look at the long-term follow-up of them, after 1 year, you see exactly almost what you had seen in the census trial, right? 20+ patients are slightly improving, up to 5%. There's a larger proportion of stable patients, and around 25-30% of the patients are progressing either by 5% or by 10% FVC, right? When you look over time and you accumulate the patients that are progressing, there are more and more patients coming that are progressing, right? While a patient in the first year might not have progressed, being one of the 70% of the patients that were not progressing, there are more patients in the second year, and more patients in the third year, and more patients in the fourth year. And overall, you have more than 50-60% of the patients that are progressing over 5 years. But what is very important is that patients that are progressing several times in those periods are very rare. Look at those numbers. Only 17 out of the 800 patients, 4%, had 2 periods in these 5 years where they were progressing more than 10%. So this is an important message, because when you wait for those periods where they are progressing, and then you switch therapy, you're missing the window of opportunity, right? Because then it's very unlikely that they will change again, right? Then you've missed the window of opportunity. So waiting for progression is probably not the right strategy. This is indicated by these data. Much better would it be to identify patients that are likely to progress and to treat them with a combination therapy upfront, right? And this was also analyzed in this paper, and you see that that is not so easy. Let's look at the multivariable logistic regression analysis here. You see that there are factors identified that are becoming significant. It was disease durations or shorter disease duration, more inflammation as reflected by ESR, but you can also take CRP here. And in our hands, it was a higher FVC at baseline, and reflux symptoms actually that indicated progression. But what you see is that on an individual case, you really have to apply your experience and your expertise if that is a patient that is likely to progress, because the odds ratios, as you see here, are very small, just below 1. So shorter disease duration is enriching for patients that are progressing. That's a risk factor, but the overall risk on the individual patient is very small. The odds ratio is just below 1, as you see. So that is our challenge in clinical practice. My last 2 slides are on tocilizumab, because that is really new data that was not really included in the consensus paper. At the time of the consensus, there was only the abstract published and not really discussed at the conferences. And now this has been published a couple of months ago in Lancet Respiratory Medicine. And the paper that is giving us the evidence is a phase 2 study that was published in Lancet a couple of years ago, and the phase 3 study that is published in Lancet Respiratory Medicine 3, 4, or 5 months ago. That was a large clinical trial. The classical trial design for scleroderma with MRSS at 1 year as a primary endpoint. More than 200 patients in the study, 1-to-1 matched for tocilizumab sub-Q versus placebo. And I think it's very important to recognize that this is a special population now, very different to the census trial, right? These are the patients that we are all afraid of. They're coming to our office, being already rapidly progressing in their skin fibrosis, very meaningful. They have diffuse scleroderma, they have increased inflammatory markers, and they are just doing bad, right? I think these are the patients that are where we say, oh my God, this patient needs something. And these are the patients that have been looked at here. And the trial is actually almost a disaster, I have to say, because the primary endpoint was not met. It's a p-value of 9%. This doesn't mean that it doesn't work against skin fibrosis. I'm hearing this very often, right? But the p-value is not met. And per definition, this is then a negative study. The p-value was 9%. This is not negative. There was a difference, right? But it's not reaching the significance level. But here you see the key secondary endpoint, and that is a confirmation of the phase 2 study already, where forced vital capacity was an exploratory endpoint. You see the dramatic effects on lung function in this patient group. Let's again first look at placebo to be really aware how different that patient population is that we are looking at here. So that is a decrease of almost of more than 5% FVC. And in milliliters, this is 190. And if you look at those patients that had ILD at baseline, because that was not an inclusion criterion, right? They could or could not have ILD at baseline. 2/3 of them had ILD at baseline by HRCT. If you look at those group, actually, that is having HRCT at baseline, the progression in the placebo group is even 250, 60 milliliters. Huge. That is what you see in IPF, a rapid progressive ILD, right? So that is much more than the 90 milliliters we have seen in the more average population with the census trial. So this is a very special population. You see in the cumulative distribution curve that the number of progressive patients is very meaningful, but you also see again, actually, that not all are progressing. There are some patients that are stable with this group, right? In the blue lines here that are above 1, but the proportion that are stable is much lower than we had seen that in the average population. And now you see the red line is the effects of tocilizumab, huge, right? It's really stabilizing with that patient group, and the average is a decline of only 4 milliliters, so it's stable actually, right? Huge differences. And because that was consistent also with HRCT quantification data, with a couple of other secondary endpoints, the FDA has, to many surprises, actually approved tocilizumab 3 weeks ago for the treatment of scleroderma ILD. So this is putting another higher level of evidence. Now one can really discuss what that means. We have 2 randomized controlled clinical trials, strong effects on the key secondary endpoints and then exploratory endpoints, consistency on the data. I still would rate that as 1. If you're very strict, you might want to label this as 2, but that's a matter of discussion. So how do we translate this now into clinical practice? What are we doing with it? We have to be aware that evidence-based medicine is great now. I think it is a breakthrough. To answer the question of the talk, I think it is a breakthrough because we have much more evidence available. So we are also lacking evidence still. For example, we are lacking upfront combination therapy studies. Can we really combine MMF and tocilizumab with nintedanib at the beginning? And is this leading to a better outcome, at least in the patient at risk? We don't know, right? There's no study that is looking at that. We are lacking high-level randomized controlled clinical trials for rituximab and actually other treatment strategies that are used and discussed. Rituximab might change soon. Then we have cross-comparison studies should not be, I think we clarified this, you cannot compare the total effects of nintedanib study census trial with the tocilizumab trial because it's a completely different treatment population, right? And we would need to study nintedanib in that inflammatory, progressive, early diffuse patient population to make a really comparison or to make a head-to-head study. Not sure if this is worthwhile to do. And I make my point, should we wait for forced vital capacity worsening to treat? I don't think that's a good idea because then we really miss probably the window of opportunity. And you will see on the next slides how I'm doing it and how we are doing it in Zurich now with Karina. How I'm asking this, do we have other manifestations that require treatment in addition to interstitial lung disease? Often that's skin fibrosis, for example, that is progressing, right? Or is at a very high level. Then I can't take nintedanib, right? At least as a single therapy because nintedanib did not show effects on skin fibrosis, right? So then I'm usually taking MMF. You can also take cyclophosphamide because SLS is showing that there's no difference in efficacy actually. But as MMF had a lower toxicity in the SLS1 study, I'm avoiding cyclophosphamide and preferring MMF. If you don't have it available, nothing wrong with cyclophosphamide, high level of evidence. Is ILD the primary treatment indication? Then nintedanib can actually be taken up front, right? Because the level of evidence is really high now. Are the patients having a risk profile for ILD progression? We have discussing the difficulties in defining that risk profile. But then I'm considering combination therapy not to lose the window of opportunity. I'm preferring nintedanib and MMF because we have toxicity data. Sometimes you can also discuss to combine it with tocilizumab. So we are then outside really of the area of evidence-based medicine. And again, if you don't have MMF, you can do that with cyclophosphamide. Again, no combination toxicity data available. If I have patients with early diffuse inflammatory skin progressive disease, that are the tocilizumab inclusion criteria, right, of the trials, then I'm using tocilizumab actually because of the strong efficacy on lung and also on other endpoints as secondary analysis. And I'm using so far rituximab as a second or third line therapy until there's no better evidence available. And once again, this might change soon. So I'm finishing with that algorithm that now Karina will talk about in much more detail. We just touched now the therapy and Karina will talk about all other points. Thank you very much for your attention. I'm a little bit over time, I'm sorry.
So only 1 minute overtime or something. So it's not so. Thank you, Oliver. Thank you for your excellent talk, like usual. So it's great that we have many drugs and the armamentarium to treat pulmonary disease in scleroderma is increasing. But what I want, maybe I'm not very well. So what I want something like in rheumatoid arthritis, so a guide or an algorithm like a treat to target, what to change, with which drug can we begin, and what's needed next. But with the last slide, you pointed a little bit. So your last slide and your clinical practice can be the beginning of such an algorithm, because it's very, you pointed very well. So my questions about when you use nintedanib in monotherapy or when you combine it were already answered with your last slide.
I think, Simona, your point is very well taken, right? Treat to target would be something that we would love. The difficulty is in rheumatoid, this is relatively easy, because that means you have to get rid of the inflammation. If you have no inflammation, that's what you would like to treat. But how do you define that in scleroderma, right? We showed the natural course that is showing such heterogeneity. And if you are stable, that might mean actually that you're doing worse than you would do, because there's in many patients a slight improvement. If you show some progression to 5%, you would say that's excellent, because maybe you have progressed by 10% otherwise without the treatment. So the individual course is much more difficult, and the treatment goal is much more difficult to define in a progressive disease with natural course changes that are difficult to predict, and much more difficult to predict in rheumatoid arthritis, are much more difficult to define. I think that is the challenge for treat to target therapies in scleroderma. But I agree, we should go on this pathway and think about more how we can define a treatment goal and add something else if that is shown. It also needs treatment. It also needs clinical trials for that, right? Remember that the treat to target trials were initiated by clinical studies that were using that treat to target and showing that patients had a better outcome than patients that were treated with the standard step up or therapy that has been used. So I fully agree. A little bit more challenging than, for example, in RA.
So first of all, it's great that we have drugs. That's very good, and it's also a very good news that tocilizumab was approved by FDA for lung disease. That's excellent, because maybe like with the rituximab in lupus, so in Romania it's very difficult to use it. We know that rituximab is working in some cases in lupus, but because we don't have the reimbursement, we can't use it, or we are using it in very difficult. So the proving it's a good beginning. Okay.
Simona, sorry, can we ask now Professor Distler some questions, or at the end?
Maybe one, because only one, not some.
Okay. My name is Magda Pagvu. Thank you, Professor, for your discuss. It's a beautiful one. For how long? I know you love tocilizumab, and you give tocilizumab to your patients with ILD scleroderma. But for how long do you treat patients with tocilizumab?
Yeah, hello Magda. Nice to see you again. I was with my Romanian friends 2 years, or how long was that ago? 2 years ago, I think, and it was a great pleasure to see you all.
Thank you.
Nice to see you again. That's an excellent question, and you know, I'm happy to know that I can use tocilizumab. I'm trying to avoid the question for how long, also with my patients, because I don't have any data and I don't have any experience. I just give it as long as they tolerate it. It's an excellent question that we need to address. And how long should that be given? We don't know. But yet, if you remember when the new treatments for RA were initiated 20 years ago, then we had the same questions. And now only in the recent years, we are addressing now how we can stop this and what happens. And I think that needs further analysis. We simply don't know. Currently, we are only using it for those inflammatory patients, tocilizumab, because we simply don't know if it also works in non-inflammatory, non-CRP, non-BSR patients. Simply speculation, we don't know. So, but that we know that the inflammatory phase is disappearing in scleroderma. And if it's true that the most efficacy comes from that inflammatory phase, which is already speculation, then we could think about that if those early phases are over, we could switch that to another more therapy that is more dealing with the fibrotic, not so much inflammatory parts. But this is speculation, right? That's probably what we should think about for a couple of years, tocilizumab, and when that period is over, something else. But pure speculation, I have to say. Mm-hmm.
And one more question, please, because you are here and it's a great opportunity. Sorry, Simona. You said in patients with profile for ILD progression, you give nintedanib and MMF. What do you mean by this profile? Because it was one of my questions. When do you give mandatory nintedanib and MMF?
Yeah, so difficult. Huh? I can't, that's like a gestalt picture somehow. It's an overall picture, and you see when a patient is not doing well with the lung function. I can't really tell why. These can be inflammatory patients. They are more progressive than others. They have anti-topo, for example, right, which is another risk factor. It's a combination of all that, right? And then I tend to, in doubt, I tend to combine upfront, because we have that situation that we showed in the user database, that there will be a progression and then there will be nothing anymore for many years, which was independent of treatment, by the way, right? Of treatment initially.
Thank you very much, Professor, and thank you for the fact that Alina Dima, who is now in your department, is one of my colleagues. And thank you both for this presentation and for Alina Dima, who is with you there. Thank you.
Great pleasure. So, Simona, thank you very much again for inviting me. It's a great pleasure to be with you, with my Romanian friends.
Thank you, Oliver, to be with us. Thanks again. It was an honor.